People want pills and the quick fix. What would be far better would be to have a healthcare system or societies that enabled safe, free exercise, and physical activity, whatever your functional or handicap status, that enabled people in every neighborhood and every income level to buy healthy foods, because those make a bigger difference. And not to have the media and the drug companies who are basically in collusion saying the solution to this is a medication.
Hello, and welcome to Not Born Yesterday, a podcast dedicated to older adults and the challenges and joys of aging. I'm Miriam Goodman.
Not Born Yesterday is brought to you by Next Village SF, a local nonprofit providing older adults in the Northeast neighborhood of San Francisco with support to help age in place. I'm Lynn Winter-Gross. The word old has many connotations. Most of them are negative. When one uses these words, sometimes images come to mind like slow-moving, sad, lonely, irrelevant. But different words to describe older adults make a difference. Our guest today, Dr. Louise Aronson, challenges us to refer to people over 70 as elders. That word conjures up positive images such as leaders, people with experience, people who are powerful and knowledgeable.
Dr. Aronson is a practicing geriatrician and professor of medicine at the University of California, San Francisco. Her award-winning book, Elderhood, Redefining Aging, Transforming Medicine, and Reimagining Life has helped change the conversation about how older adults are treated by the medical community and how the rest of us think about aging. Dr. Aronson has written that our time on earth is defined by childhood, adulthood, and elderhood. She says elderhood has many variations and can last 20 or 30 or even 40 years for many people. While she's written a lot about these issues, today we're going to focus on her insights about how elders deal with and are treated by the healthcare community. Dr. Aronson, welcome to Not Born Yesterday.
Thanks for having me here. I love the title of the podcast.
Thank you. Dr. Aronson, you said that the medical community does everything possible to keep people alive, and yet doctors treat us getting older as a problem, as a disease. Why is that?
Well, I think it's in part historical, that for most of human history, we died young. And so as science evolved, particularly in the 20th century, the goal was to combat those diseases that were killing people. In the first half of the century, you tried to have women not die in childbirth and tried to have children not die in their first few years of life, and that succeeded. So then they started tackling the diseases of more middle age at that time. Now we've shifted those a little later, but things like heart disease in particular, we've made huge strides there, high blood pressure, stroke, etc. And so it seemed logical at the time. People are dying, they're dying of conditions we know about, let's tackle those conditions. But I think maybe because it's unprecedented in human history, it didn't occur to them like, okay, so then people will be alive and then what? And so now we have people living for generations. I mean, I now have 2 generations of patients in my practice, sometimes 3, living for generations through old age. And medicine, although this has been happening for the better part of a half century, is still very focused on diseases and organs and not thinking about our lives and the consequences of saving someone's life so they could live to be in advanced old age, for example.
We've heard that the amount of time medical schools spend teaching about aging issues is relatively small compared to pediatrics or orthopedics or cardiology and other specialties. So why is it that the whole area of geriatrics has seemed to be ignored in the medical teaching?
Yeah, so you actually framed that really politely. It is hugely disproportionately underrepresented. There are weeks devoted to old age when, in fact, older people are 17% of the population, and a much larger, like double that for hospital stays, and more so even in the outpatient sector. So just as schools and education is primarily focused on kids, healthcare has a lot of focus on older people, but yeah, we aren't taught about that. So I think the reasons have to do with the healthcare system being populated by people and people being notoriously ageist. Sometimes intentionally, sometimes unintentionally, we all begin young. But people spend a huge part of their old age pretending they're not old or not as old as, or all sorts of things. It has become the cultural standard, and it's fairly universal. So I don't say this as like, you're a bad person if you're ageist. It is highly atypical not to be ageist. So I think what we need to do now that we're all living to be older people is work on our ageism. We know that can be done as people have made progress in a bunch of other sectors. The second area is partly something that's harder to fix. So medicine was really focused on men until women started going to medical school. With feminism and sort of in the 70s, and then we got women's health, and now we have a lot more research on women and things about women's health beyond the female sexual organs. Then in the 90s, we started including more diverse classes, more people of color, more people from different backgrounds. And now we see the ways in which we harm people from those backgrounds, just as we harmed women, and we're working on diversity. And that brings me to my last key point, which is I think we in geriatrics and people in gerontology are their own worst enemies. So the common lament is, well, because of ageism, there are so few of us. Because there are so few of us, we're going to focus on the oldest and frailest. Do I believe the oldest and frailest deserve outstanding medical care? Without a question. I've devoted my life to this in part. But the initial idea of geriatrics was as an analog for pediatrics in kids and internal medicine in adults. In other words, pediatrics covers neonates through teens. Adult medicine covers young adults through people in their 60s. Geriatrics, if we only focus on people over age 85 or frail, is not doing its job. We should be starting to take care of people, there's accelerated aging from 60, 65, 70 upward. Healthy older people, not healthy older people. If geriatrics were what it should be, a big area that focuses on the diversity of old age.
But you decided to go into geriatrics. So that you must have been very unusual in your medical school class or whenever you decided to go. So how did you decide to do it? And what was the reaction when you decided to do something so different from, I assume, your other medical school classmates?
So I did internal medicine, and it was sort of happenstance as a resident that I found a few things. One is I loved older people because they have, I like people. And if you've lived longer, you have more stories and more interesting things have happened to you. It's medically more challenging because lots of different things are going on. And it doesn't let me focus on just diseases or organs. Some people like to just think about the liver or just think about a particular kind of cancer. I like to think about a person. I'm interested in the liver or the cancer insofar as it's affecting a unique human being. And geriatrics, especially when you're dealing with frailer people, you have to consider who the person is, what's important to them, where do they live, who's in their social network, all these things that are of interest to me. So people thought it was, unusual.
Since we want to talk about how we want to change the way medical care is delivered to older people, can you give us some negative and positive ways that elders receive healthcare today?
Well, negative ways, sometimes people are just told that what they have is because they're old, and so there's nothing to be done about it. You're in pain because you're old, or, one of the jokes I put in the book is a true story from New York. An older man, I think he was 94, went in with pain in one knee, and the doctor examines it and says, well, I can't find anything wrong with it. It's probably your age. And the guy says, well, my other knee is also 94 and it doesn't hurt a bit. So old age is a risk factor for disease, but it is not a diagnosis. So that's one of the ways people are harmed. They can also be, so we call that undertreatment. There's also overtreatment, which is when you take particularly like a frail person or an ancient person, and you say, oh, we have studies showing this treatment works well, when the average age in the study was 48. And so you give it then to the 88-year-old or the 102-year-old, and they don't fare as well because their organs are different and their function is different. Positive things are all sorts of ways. We have all these innovations. They're not as widespread as they should be, but there are things like in the hospital, there are acute care for elders units. which pay attention to the fact that if you are in bed for a few days, walking is going to be hard. That's true at any age, but it's going to be even more hard as you get older if you don't get mobilized sooner, even if you were a healthy person to begin with. So it really, these innovations take into account what's different about your older body and what's different about your priorities and adjust the care appropriately. Similarly, in the outpatient setting, we're, like one of the things I like to do a lot now is thinking about how active a person is. I was just talking about women and aging, since women are much more likely to be old. And there's this great statistic where women who are more physically active, so women usually have much more disability than men as they age. Men are more likely to die, women are more likely to be disabled. But women who are physically active as they age are no more disabled than men. So there are these things we can do to encourage people as they grow older. Yes, what you eat still matters. Yes, moving still matters. It may look different than it did 10 years ago or 50 years ago, and that's okay. It's the moving that matters. So there are so many ways we can take that into account. Medications, treatments, everything. A medication may be just as helpful in an older person, or it might be harmful for a variety of reasons. The liver and kidney metabolize it more slowly, so the level of the drug may be higher, which means your risk of toxicity are higher. Anyway, I won't go on and on, but there's so many examples, I didn't even know where to start.
You talked about, and I read in your book that doctors find it easier to prescribe treatments for disease like chemotherapy, dialysis, and surgery. And they spend less time talking to elders about possible things that they could do to avoid disease, like exercising, as you've been talking about, learning new things, socializing. How is that going to change that we can get our doctors to talk more about one thing versus the other? Are they getting paid more for prescribing these treatments?
Yeah, so the whole system is stacked. A medical center will get paid the most if you're in intensive care, the next most if you're in a step down unit, the next most if you're in the hospital. So doctors get paid more to work inpatient, the hospital makes more money, the more procedures they do on you, the more money they get. By contrast, what do we want as human beings and as patients? If we need care, we'd much rather be at a health status that we can get it in a clinic. We'd much rather not need procedures. We want preventive health care. But the US has one of the worst primary care infrastructures, and we don't even do what's called social care. So medical care is sort of medications and treatments. And social care are all the supports that help you function and live your life in the community. Of the 11 most wealthy countries, we're the only one who pays no attention to any of that. So I'm digressing a little bit, but I think the single biggest thing we can do that would help get us the preventive health care that we need at all ages is to vastly expand primary care in this country, give primary care physicians the same salaries people get for doing specialty care, and give them more time with patients. You can never figure out who a human being is or do appropriate counseling with them, or discuss complex health issues in 15 minutes. You can't do it. But people want pills and the quick fix. What would be far better would be to have a healthcare system or societies that enabled, safe, free exercise, and physical activity, whatever your functional or handicap status, that enabled people in every neighborhood and every income level to buy healthy foods, because those make a bigger difference, and not to have the media and the drug companies who are basically in collusion saying the solution to this is a medication. For some diseases, the solution is a medication, but for so many things, medications are like a Band-Aid, and you could actually have a cure if people had the time to explain the benefits of the changed behavior that we know makes a big difference. Is it a solution for everything? No, but actually, like, physical activity is the only thing that treats all the following diseases: diabetes, high blood pressure, heart disease, certain cancers, insomnia, anxiety, overweight, it just goes on. Parkinson's, Alzheimer's, treats or prevents. That we don't have any medications that are that effective. And yet there's no time or energy for that.
Dr. Aronson, another thing I hear about a lot is when older adults bring their adult children with them to the medical appointments because they want somebody there listening with them. And then the doctor frequently just talks to the adult child as if the patient isn't there, can't understand, whatever. How do we deal with that?
Well, I think maybe three prongs. So the older person should say, as somebody did to me yesterday, actually, she did a great job. She says, I've got my daughter here to be like a second set of ears and to help me remember things if I need to. And this was actually a telehealth visit, but I couldn't see the daughter. So she was off camera. She didn't interfere. Perfect. If you're there in person, you can also say, look, she's here. And if I need, corroboration of something, I'm going to ask her, but otherwise she's just sitting there. And then, the daughter or son, I mean, it's usually a daughter, but sometimes it's a son, needs to be quiet also and defer to their parent. Look, if the clinician is looking at you, look at your parent. Everybody can be part of the solution. And then the older person just keeps claiming that space because there is also this internalized ageism, and you can let yourself be talked over. Also, sometimes people aren't remembering something, or they can't express it as quickly, or they're telling a story. Well, that's not necessarily a problem. It's been created into a problem because of these 15 or 20-minute appointments, right? We know sometimes things happen more slowly as we age. Why not have a system that accommodates that? And then doctors need to be reminded constantly, like, you speak to your patient. You don't speak to the interpreter. You don't speak to the adult child. And if you're going to speak to the adult child, one of the things that's helpful to do is to say to the patient, I'm wondering if it would be helpful to include your son at this moment. How does that sound to you? And it becomes the patient's decision because it is the patient's visit.
Well, that's a really good suggestion. And it goes with my next question is really, for those of us who are at the stage of elderhood, we always like to give them a call to action, something that they can do themselves to change the way things are if they don't like them. So what do you suggest that each of us do the next time we have to deal with healthcare professionals to make sure they respect us and listen to us?
Mm-hmm. Ooh, so many things. I would say, go in confident, knowing that your problems are legitimate. You need to be listened to. If you feel like they're not listening, say, I'm so sorry, I just need to interrupt you here. One of the main things I came in to talk about today was my knee. And I don't feel like we really have a good strategy for diagnosis or treatment yet. Can we just come back to that, please? And keep them focused, because that does two things. It tells them explicitly what you want, and it asserts you as a competent person who knows your rights, not just some person to be brushed off, which we hear about happening or at least I hear about it frequently, given my various roles, happening with other people. So, go in knowing your rights, knowing what you want.
That's great information and very helpful. And I want to ask you if there's anything else that you think we've missed. And is that 15-minute appointment going to ever become 20 minutes or 22 minutes?
It has in some places, and there are places that will allow more time, given complexity or age. So ask about that. I would say start making noise. We hear, admittedly, pandemic interrupted absolutely everything. But we hear about all sorts of problems, but I don't see a groundswell of people saying, this isn't enough time. It's like everybody's so beaten down, they just take it. Or they'll complain when they're in my office, like, oh, it's so nice you're looking at me. I went to so-and-so and they just typed the whole time. But realize that's part of a systematic problem, because if I don't type, then I'm typing for several hours that night or at 4:30 the next morning, or when I get the note saying, where are your notes from Tuesday? Which we get these emails. So we have to make it viable. They might be typing because they have an 18-month-old and they'd like to get home and spend time with their child. And so they're put between a rock and a hard place. So this is a problem that needs a solution for both patients and clinicians. And we should be working together and making a heck of a lot more noise.
Thank you so much. This is so much good information and a lot for us to think about. That was Dr. Louise Aronson, author of best-selling book, Elderhood.
Today on News You Can Use, we're talking to our younger listeners as well as the older adults. Research has shown that many boomers still expect to receive some kind of inheritance when their parents or other family members die. The advice here, don't count on it. Some have been blaming the falling stock market and other financial woes on the fact that baby boomers are now collecting Social Security. That's not it either. That money is yours. You earned it, and it has been kept out of the financial market as its own fund just for you. But it's true that many boomer age adults are counting on an inheritance to supplement the funds they will get from Social Security, pensions, investments, and savings.
Today's reality is that your parents or other relatives who may have indicated they are leaving you something have a lot of demands on their own money today. So that money that you were hoping would be yours may have already been spent. But as the older generation continues to live longer and medical improvements have made it possible for people to live longer than ever, the pressure on our nest eggs will only grow. We've all heard older adults who purchase a new car or sign up for a trip say, I'm spending my child's inheritance. The truth is that many people, even retirees with a good net worth, could end up spending every dime before they die. For those who thought they'd have something to pass on or that money would be coming to them, here are some of the things that may get in your way.
According to the National Center for Health Statistics, males age 65 could expect to live to 82. For females, it's 85. That's a lot of years of living expenses, no matter how you adjust your standard of living. Medicare and Social Security will probably change in the future. Medicare premiums will go up and may cover fewer procedures or not cover emerging ones. Meanwhile, taxes on Social Security benefits may rise, and everyone may have to wait longer to collect.
Fewer people have pensions, and statistics show that 63% of workers in the private sector work for employers who only offer 401ks or similar plans, not traditional pensions. As pensions continue to disappear, retirees and those who are close to retirement will depend more heavily on how their investments perform. I don't have to tell you what that means today. COVID, the war in Ukraine, and inflation didn't figure into our original estate plans. For those who don't have health insurance paid for by their employers, you may need $225,000 at least to cover healthcare costs for retirement, not including over-the-counter drugs, dentistry, or rehab, or nursing home expenses.
Divorced individuals may pass on even less money. Splitting up can be expensive in itself, and maintaining two households for decades afterward costs more than sharing a dwelling. Even if the parents have money left over, the ones who didn't have custody of the children may be less inclined to pass on an inheritance to them. Still, the transfer of wealth today is happening while the older generations are still alive. They are often paying college tuition or camp fees for grandchildren, chipping in when children or grandchildren graduate with large student loans, supplying down payments for a house, and helping younger generations out of other financial disasters. Sometimes this is part of a concerted effort to reduce an estate that could be subject to taxes, but other times it's pure necessity. So don't count on inheriting a fortune unless there really is one. And if you're fortunate enough to receive such a gift, put it to good use now so you won't have to choose between draining your home equity and leaving something for your kids.
And that's our podcast for today. Our thanks go to our guest, Dr. Louise Aronson. You can learn more about Next Village SF at their website, nextvillagesf.org. Our theme music is from Hook Sounds, and Jason Dahlstadt is our engineer. And thanks to you for listening. We'd love to hear what you would like us to discover and discuss. Please contact us at nbypodcast@nextvillagesf.org. Be well, stay strong, and remember, you weren't born yesterday. I'm Lynn Winter Gross.
And I'm Miriam Goodman.